Thanks, Tony. Before I start, I wondered whether you would mind if I stuck to a very, very important tradition that I think is really worth preserving as part of this show, and that is I'd like to acknowledge the traditional owners, the Whadjuk people of the proud Noongar Nation, and pay my respects to elders past, present and emerging, and remind us that our job is to think of others always, and that be at the heart of everything we do. So this is a really unusual day. We're running this technical pilot. I really want to thank you, Tony, as a DJ who's helping guide me through this first technical test run of using radio as a medium to communicate in these, what everyone keeps on calling unprecedented times. So Tony, thank you very much for your personal time and dedication. I know that you give a lot of time up for children, and I also want to thank Radio Lollipop generally. So thanks ever so much. I love you in your headgear with your headphones, so thank you.
Wonderful. No, thank you, and welcome to the studio. And yeah, very good. And over to you.
So, Tony, this represents a collaboration between CAHS and Radio Lollipop, and is our attempt to try and find a medium through which we can communicate a little better. The last time we ran a staff forum, we used Scopia, and as you know, we were unable, it took up a lot of bandwidth, and we therefore failed to communicate. So we're going to try radio as a medium. It reminds us of times past as opposed to the new digital age, but it's still able to communicate with people. What we're trying to do with this show is to provide everyone with updates, try and talk to some of our staff who lead interesting lives both at work and outside, and offer an opportunity for people to ask questions. We've got a telephone line, 6456 5629, and our special guest today is Valerie Jovanovic, who's joined us as the Exec Director for People, Culture and Capability, and she's just walked into the studio. That's not a word I thought I'd be using before. So maybe if I can start with just a bit of background, which we normally provide in staff forums. The first is I really want to acknowledge the hard work and disruption. It was described almost like a fog of war the other day to me by someone. I think most of us normally have great clarity around what we do on a day-to-day basis, but everyone's life's been turned upside down, both at work and at home, and I think that's a really difficult and challenging thing to deal with. So I really want to thank each and every member of staff at CAHS, both within the hospital and our community health services and CAMS, our mental health services, for their professional approach to ensuring that we maintain our services and meet the needs of children and families out there. It's been interesting because the main thing everyone's talking about is a digital transformation, but there's a lot of interaction still going on directly with children and family. It's interesting to look at how COVID's affected us in terms of patients presenting, and I just got some data or information that was uploaded and is complete as of midnight last night, and the numbers show that we'd had 633 patients through our emergency department who'd been tested for COVID, 116 inpatients who'd been tested for COVID, 10 outpatients who'd been tested for COVID, and as a consequence, that's a total of 759. We've only tested one positive here, and children, there are only 9 children that we're aware of who've tested as positive. That is children under the age of 16 who've been tested positive for COVID. So it really is looking as if the numbers in Western Australia reflect exactly the same as those from elsewhere in terms of this not being a disease that we are seeing in terms of clinical presentation very frequently in terms of our children and families and the effect it has on them. The other bit of information I thought I'd reflect on is the concern that is being expressed in terms of the numbers that we're seeing presenting to our emergency department that have been significantly reduced since COVID became a real part of our lives. We normally, I would say, have about 170 or 180 presentations a day to the emergency department, and this is significantly reduced with numbers looking more like 80 to 100 per day. And obviously our big concern is that children who should be presenting to ED are not. It's difficult to know what that's due to, but what we are keen to promote amongst families is that, as it were, we are open for business and we're here to care for people, and COVID has not limited the range of services that we provide acutely to children. So if you are able to promote the message around the organisation being there for families at their time of need, I think that would be really useful. I think the second bit is many people are asking what next. So there's been huge upheaval in order to become prepared to address COVID. I think we've got to celebrate the enthusiasm and amazing way in which both our staff and the people of Western Australia have pulled together and complied with social distancing and isolation to flatten the curve. And it looks as if the pattern that we'll be expecting in the future is potentially one where we'll see clusters of infection presenting. But we're still in a planning phase, and I think for us we've just got to be cautious that we don't start running before we can walk. And we as an organisation have been discussing what next steps could be. We are just about to try and pull together a planning ahead team, and that'll work with you to try and see what the future should look like, because there are some bits that we just cannot turn the clock back on. So with that, I just wonder whether you would mind if I move on to the next stage of the programme, which is to have a conversation with Professor Chris Blythe, who's joining us to help answer some questions.
Thanks, Aresh. Yeah, we're just going to put Chris on, but don't forget to give us a call on 6456 5629 if you've got any questions, or you can text on 0436 595 600. So we'll be opening up later on in the presentation to calls, but we'll just now hand over Chris. Chris, are you there?
Yes.
Chris, over to you. Aresh, all yours.
Chris, welcome.
Thank you.
Chris, this is a very, very unusual phenomenon. I don't think I ever anticipated interviewing you in a radio sense. So do you mind if I just start by formally introducing you? I know you're an immensely well-known and popular figure in CAHS, but at the other end of the line we have Professor Chris Blythe, who is traditionally head of our infectious disease service at Perth Children's Hospital, a researcher at UWA and Telethon Kids Institute, and really as a reflection of the high regard he's held in, he has currently on a secondment with the Department of Health, leading a program of work around PPE. Chris, I know you have many more titles, but does that capture the essence?
It does. Thank you very much. Yeah, I am with the WA Health at the moment, trying to work with them to make sure their PPE plans are as up to date and consistent and robust as possible.
Chris, I just wondered whether you could do a bit of reflection around PPE for us at the moment. I mean, globally, it's obviously a big feature in the news. And locally, it's one of the biggest topics that staff discuss on a daily basis. And I wondered whether you had some reflections and just an update you could provide us around PPE.
Sure, and I'm very happy to. And I think that the first reflection is actually how lucky we are to be in the position where we've had sufficient time to do the planning that we have done, but also are continuing to do, so that we don't find ourselves in situations like we see on the nightly news of people wearing garbage bags and ski masks and things like that. You know, terrible situations where people have been left without the feeling of being protected. So in the PPE space, really, I've been with WA Health about 3 weeks now, and even during that time, we've been able to source additional PPE into the West Australian stockpile, so we have a West Australian stockpile for PPE. That means that we've got a robust and healthy supply. Now, of course, there's always uncertainty about how much you need, and so we're continuing to reach out internationally at a time when actually the market for PPE is clearly very tight. But we've got some fantastic people really trying to make sure that we've got adequate supplies. I suppose along with that piece is really making sure that we've got a well-trained staff who know how to use their PPE, know which situations to use their PPE, because staff safety is our number one priority. I think we're also in a very lucky position now that we can actually, now that the numbers have really dropped away, be having the conversation with our staff to say, actually, do you know what, PPE is really, really important, but we probably don't need it for every patient, and that is our advice at the moment. Actually, most of the patients coming through the health system at the moment are at incredibly low risk of COVID, and so we need to have an appropriate response at this stage. Western Australia has not had a case for the last 7 days. We've actually had one last night in someone who's a return traveller. But as far as locally acquired cases, we have had very little activity for the last couple of weeks. So we're in a wonderful position of low activity at this stage. So our challenge is to make sure that our staff and the community at large understand the importance of PPE, but also understand about its appropriate use.
So Chris, I just wondered whether if there was anything specific about healthcare professionals who looked after children that would alter the way in which they approach PPE. I know that the guidelines have been changed, but initially there was some concern, I think, with the earlier version of the PPE guidance that maybe the way in which children would be managed would be different to that of adults. Just some advice would be really appreciated.
There's a couple of things in that piece. We know from the international literature that children actually are a much lower risk of getting COVID-19, which at least for those who work in paediatric practice should provide some reassurance. However, we do know that children can get COVID-19, so therefore we do need staff to be aware of how to look after patients with COVID-19. The other challenging piece we've got in paediatric practice in looking after kids is I don't think I'm going to be able to distinguish someone who's got COVID from another respiratory virus. So, importantly, we need to have clinicians thinking about how will I do this, particularly at a time when the winter viruses start to circulate. As a bit of a segue, though, we've actually had a real drop in the number of people presenting with respiratory viruses in light of what's happening with our isolation from each other. So really our activity in that space is really low. But our advice will be to use specific PPE when we're managing people with symptoms of acute respiratory infection. And so for the vast majority of healthcare workers managing someone who has an acute respiratory infection, so cough and fever and breathlessness or sore throat, is to use standard PPE, which would be a surgical mask in this sort of situation. There are some very specific situations of procedures that increase risk, and there's advice that we give to those doing those procedures. But for the vast majority of staff, it's business as usual, except for dealing with people with acute respiratory infection, which is really adopting the PPE as recommended.
That's brilliant. Chris, can I just wonder, while we've got you online, whether I could ask you a couple of questions. Actually, one of them is around this challenge of symptoms. So I think, if I'm right, you're involved part of the DETECT study that's been announced by last week in schools. Am I right in that? I know Dr Asher, Peter Gething and TKI are also heavily involved together with WA Country Health Services. And for the Child and Adolescent Health Service, Terry Barrett is helping lead the operational deployment around that. But I wondered whether there are any reflections you wanted to have on that study, the DETECT study, and whether there were any plans to test frontline staff who may be asymptomatic for COVID-19.
There's a couple of things on that, Aresh. We need to increase the amount of testing we're doing because it is the best mechanism we have to detect coronavirus in the community. We're doing a lot of tests at the moment. We did 8,000 tests in Western Australia last week, and that continues to climb. But with coronavirus being an ever-present threat as far as being reintroduced, we need to make sure that we've got a broad reach with our testing, that we can identify somebody in the community and then have a public health response to that. Now, the majority of that testing should be being done in those with symptoms, but a small proportion is going to be done in those without symptoms to really understand whether there is coronavirus in the community, even though we're not seeing it at this stage. The DETECT series of studies, and there's a number of studies, not just in school kids, but in other populations, are specifically trying to answer that question. Do I see this being a long-term thing? No, it's very much a short targeted program to really say, are we detecting it in schools or in specific populations? Because that will help us understand what this virus looks like in the community at the moment, and I expect will show there's actually no virus or very little virus in the community at the moment. I think the activity we're seeing in the state numbers is real, and this will provide increasing confidence that that is the case.
That's brilliant, Chris. I'm sorry, I've got a number of questions from callers, and I'm just going to put those to you. Can I just pick your brain then about this second question, and it's around herd immunity, and it says, has it been established whether community exposure offers herd immunity?
Good question. So one, we know that coronaviruses, when they develop immunity, usually provides protective immunity. We saw that with SARS and also with MERS, and we will know that with coronaviruses. We do not have great data on that as of yet because you need to have that in the community for a long period of time. What I do know is that in Western Australia, though, we have very little immunity. So we are a susceptible population. So all the interventions that we can do to try and prevent the incursion of this virus into the community are important. The difficult conversation to have, though, is the only way out of this problem is immunity, whether that be by a vaccine or by people getting infected. And that's a challenging concept for us all, not only those who work in healthcare, but those of us who have families and those of us who, when we think about our friends and family.
Chris, that's great. I suppose, am I right in saying you don't see a sort of an immunity passport being imminent at the moment?
I don't see a pathway to immunity in the next number of months. Yes, there's a lot of tremendous work that's occurring nationally and internationally as far as vaccine development, but knowing the challenges in vaccine development from a research perspective, it is going to be a while before we have a vaccine that's ready to go into the arms of West Australian children and adults. And so what we're doing now, we need to have many of these things in place for a longer period of time. I think the other important thing is as we start to back off some of the restrictions, we need the capacity to move swiftly and move back to some level of restrictions if we do see activity that is more than we would like, so that we have the ability to put the levers on and off to try and control this, because we have to control this. The option of letting it run through our community is clearly something that is unpalatable to us all.
Chris, can I just pick up on one of those elements, because I've got a question about it, and I don't know how much of a generic response you can get. And the question is, how would vaccination against COVID-19 work?
Well, the first step is developing an effective vaccine, and that development process is actually a relatively complicated process. One, you need to take it through both animal and then human trials to firstly know that it's safe, secondly, to know that it works, and thirdly, to know that it actually lasts over a period of time. If you've got a candidate vaccine that you've taken through those trials and you're comfortable with that, the Therapeutic Goods Administration, as do many of the regulators, such as the FDA or the European regulator, have fast-track mechanisms for life-saving treatments, and in many ways this would be invoked in this sort of situation. And then realistically, once the TGA has approved it, it would be taken through the national bodies in the vaccine space, which I sit on, and that would be saying, does this vaccine have a role, and how we roll it out? And once we had it there, then the challenge would be, how do we distribute it? How do we make sure that those who need it can access it equitably? How do we run the programs to try and get a large population immune? From what we know, clearly, those at greatest risk would be a target. So how do we make sure our elderly and those with underlying risk factors are the people who are first to get this vaccine?
Chris, thanks very much. I'm going to take home one simple message from you overall, and that is we're in a fabulous place in both Australia and in particular in Western Australia, but there's no room for complacency.
I agree. There's no room for the complacency at the moment. We all need to work together. Importantly, we can do that, and we've been in a very lucky position to have some of the time to do that planning.
That's brilliant. Chris, thanks very much for giving it your time. We really appreciate it. Good luck in your continued luck in your current role, and we're really looking forward to welcoming you back fully to CAHS.
Cheers. Thank you.
Take care, Chris. Have a lovely weekend. Sam, I'm just able to move on to the next section, and I'm pleased to be able to introduce Valerie Jovanovic. Valerie, welcome.
Thank you. Thank you for having me, Aresh. This is, how fabulous is this?
It's fabulous and surreal. So, Valerie, welcome. How long is it that you've been at CAHS now?
It will be close to my 3-month anniversary on the 17th.
Oh, not that you've been counting.
No. Loving every moment.
So I just wondered, Valerie, you're new to CAHS, but you're also new to Western Australia. I just wondered whether we could start by you just giving us a bit of your background, and then maybe we'll talk about how you see this current role evolving.
Absolutely. So my background, I'm from New South Wales. And they shut the borders right behind me from New South Wales. So I'm a nurse by profession, a registered nurse, and still registered in the perioperative area. And I love my nursing career, but I've had a broad range of experience as well in both management and at an executive and senior executive level. Spent many years in medical administration, as well as corporate, as Director of Corporate, and the last 5 years as General Manager. So my first 3 years was, for those that know New South Wales, down in the beautiful Southern Highlands of Bowral, which was a fantastic experience. And the last 2 years of Sutherland Hospital in the Shire, as well as I had responsibility for the governance of the Garrawarra Centre, which was in the Royal National Park.
Wow, that's amazing. And General Manager is the same as Exec Director as we know them in Western Australia?
Correct. So I was responsible for the site as a whole, and just absolutely love that experience, and particularly around the notion of leading my team, leading the organisation. It was a privilege, and the culture aspect, which I'm sure we'll speak about just momentarily, was the passion that I had in that role.
And what brought you across to WA?
Well, if I can be honest...
You can always be honest.
It was love.
Oh, right. That's not the answer I was expecting. I thought it was CAHS, but...
The love of CAHS, absolutely. And I'm happy to share, because I'm sure it's not just between you and I, Aresh, here.
It is, it's private.
It's very private. I reconnected with a high school love, who moved to Western Australia a few years ago. It was close to 20 years ago. He flew me out, and his first date was out at City Beach watching the sunset. And I knew at that point in time, I have to move over here. This is just the most gorgeous part of the world. World's best kept secret. And over my time during our long distance relationship, which went over across 12 months, I spent a lot of time starting to connect with WA Health and understanding that better. And ensuring that we had some networks and making some connections. And when this role came up, and I learnt a little bit more about CAHS and spoke to yourself, Aresh, I was just drawn in terms, particularly around that values-based leadership and organisation. It just really drew me in.
And could you just reflect on that? I mean, just in terms of how you see your current role evolving. And I think we'd really be interested in hearing what you see as some of the challenges going forward.
The role traditionally under the portfolio does have workforce, HR, IR, learning and development, but also the culture piece, and they all triangulate. In terms of the challenges, and particularly I think with what's presented to us through COVID, is that culture is based on relationship building, the notion of trust, good leadership, but also the seeing of actions, accountability, and progress, and really good communication for staff, and creating an environment where our staff feel empowered, nurtured, and that it's a great place to work. Given that many of our staff spend a lot of time here, this becomes your family in many ways. It's so important that we invest in our people, because there is a direct correlation between the investment we make in our people versus our patient outcomes. So we can focus on families and patient outcomes, but until we have an environment where our staff thrive in our organisation, we can't do that. So in terms of the challenges that I think COVID has presented is that relationship building, because we need to consider that in a very different way, particularly for myself in coming in as a new staff member and attempting to make that connection, because usually it would be face-to-face, building those relationships, bringing people together. So I really have to think outside the box in that sense.
And look, that's so beautifully and articulately put. I just wonder whether... And it makes sense, and one would say it's a no-brainer. I just wondered what you thought some of the challenges specifically were in terms of trying to achieve that goal and aspiration for CAHS were. Do you have any early thoughts, Valerie, about that?
The most important thing is how we involve and engage our staff in the process, and that it's relevant for staff. There are a couple of, there's some areas that we're looking at, and wellbeing is one of them, for instance. We held our first think tank group this morning, and it poses so many opportunities for us to offer our staff level of support around that, but it means different things to different people. So the challenge is, how do you shape that so that it is relevant. So I think the important thing that we need to do in moving forward is keep engaging our staff, ask the right questions, but then when the feedback's provided, that there seemed to be a level of action in terms of you said, we did. I think that's very important.
Yeah, I agree. I think that's one of the frustrations many staff reflect back, that actually we're not short of staff who are really, really engaged and have great ideas. But I agree with you that we really need to work on our delivery. Are you able to share any early thoughts regarding well-being? I know that you put a framework out, it was I think last week, and any discussions that occurred in the think tank, or is it too early, and are you breaching some secrets?
No, not breaching some secrets. There's some wonderful work already occurring in different spaces. So one this morning was about sharing some of those ideas and considering the best way forward with that. We're conscious that one aspect of it is a management piece in terms of what we need to set up and manage that and govern, and our due diligence that needs to be available for our staff, particularly from an OSH perspective. But then it's also the person-centred ideas, and for staff to understand what is the process, so that if they have an idea that we can take forward. I think there can be a suite of tools available for staff, but I think as an executive and as an organisation, we need to look at what areas will we decide to invest in and really roll out and promote and make that our brand in terms of what we'd like to focus. But I don't want to make an assumption that what we roll out is what staff actually need. We need to find out that information from staff. But I think what I bring to the role is my leadership characteristics, which one of them is that whole leading with heart notion. So I think we need to maintain that heart piece in part of this process. Not
lose it. I mean, it's been interesting, isn't it? Because I think one of the bits of feedback has been to ensure that we maintain compassion for our colleagues during this period of really significant stress for everyone, as I mentioned earlier, with upheaval both at work and at home.
In saying that, compassion is very important, you're right, and there has been absolute obvious demonstration of both compassion and empathy But one, it's understanding both of those terms and what they mean. And compassion, actually, you can suffer from compassion fatigue. What happens is that it actually does take a lot of your energy and internal resources and thoughts to be able to display compassion, because it's actually wanting the feeling to take that pain away or feeling away from somebody else. So we've got to be conscious of that, because a lot of that occurs in our organisation, and there are risks involved individually with that. So we need to have support and an understanding of what compassion actually looks like and means, and how we support it.
Yes, I mean, it's compassion fatigue is something that's been talked about in organisations, I think, and is a very strong and emerging theme.
Yes, and for CAHS, the Shape Our Future committee has really focused on that space, and we did hold a presentation just at our recent meeting. So we've got some interest in understanding that a little bit more, and taking it further in terms of rolling out the notion of compassion, but also support for our staff to be able to do that.
That's brilliant. Valerie, look, as you know, that I'm being held to a very tight timetable by Beck, who spent weeks together with Chris actually helping pull this show together. And I wondered whether you would mind if we just moved on to a question and answer session. And of course, people can ring in on 6456 5629, or I understand text 0436 595 600. So we've had the first question, I think, come through. Do you mind if I pick your brain around this? Because I know you've been working very hard around this framework. So
it's probably my mother, isn't it?
it might be, actually. They're anonymous.
Might actually be your partner. Your partner dobbing him in. What could have been?
So look, I think this is something that has caused concern, because I think there's an issue around making sure that everyone in the organisation is treated equally. That's certainly been a couple of questions that we've got. But this one is, and I'll just read it straight out. I'm concerned for staff with comorbidities. I know that some teams have enabled working from home. Why has this not been rolled out expediently at an organisation-wide level?
Thank you. It's actually quite a pertinent question at the moment. The whole piece of work around working from home did bring its own challenges. We needed to ensure, as you mentioned, particularly in the sense of equity and fairness, that we had a process in terms of priorities, an assessment of positions, and determining which services would actually be suitable to work from home and not. And then, of course, yes, our piece around staff with a medical condition that does place them at a greater risk with COVID patients. So our workforce survey, and thank you to all staff that completed that, because it was quite important. There were up to 80% of staff that completed this survey, which really helped, because it gave us a detailed information to be able to go back to staff and have the notion of if you did tick a yes in terms of that you felt you had a medical condition that should be discussed and considered, that there was a process set up, so it automated both an assessment from a risk assessment point of view with managers. Now, we're conscious that was a point in time in terms of a survey, but if there are staff out there that do feel we need to still have a conversation, please do not hesitate to contact your manager and have that discussion. If please contact HR or myself, and we'll be more than happy to help guide, because look, it is a very individualised assessment based on the condition, your roles, and how that fits in with the organisation. And it's very important that we do individualised or set up a plan around that.
Valerie, I just wondered, because I know that we had a lot of discussion around this, and I just wondered whether you would mind if I reflected on some of the discussions that occurred. So, and this has been one of the most difficult issues around working from home. So I'm just going to make some off-the-cuff comments as the text has just come through. The first is that the principle of making sure our staff are safe has been at the heart of every conversation we've had. Of course, children and families, but the staff have to be safe in order for us to be able to deliver care. So earlier we touched on PPE as one aspect of that, but ensuring where we can, driving social distancing, promoting infection control measures, and acknowledging actually that the vast majority of our staff are involved, not all, but a vast majority of our staff are involved in aspects of care that involves delivery at site level. So this working from home is a concept that I think emerged right across the planet very, very quickly. And there was certainly in a state where we have a lot of large businesses, there was an immediate assumption, I think, that it could be translated right across all aspects of government as well as industry and business. And so I think we just got to be cautious. It's an easy term to use, and it can appear to be that we are over-promising and under-delivering. I think the second thing for me is that one of our challenges that came was that we mustn't lose our sight around equity and access, and making sure those who were working from home could continue to work, that we had the tools to enable them to do that, and it didn't seem as if we were favouring one group over another. So there were two aspects from my understanding of how this was implemented. The first was to assess the job itself, yes, to ensure that we had the tools, and to ensure that that was distributed in a fair, equitable and accountable manner, with a very clear ability for us to go back and look and justify or be challenged around our decisions. And the second layer that came onto that was understanding our colleagues and some of the challenges they faced, including potentially their own health.
That's right.
So I think it's a really good question. I do worry that term is branded around a lot, and we appear to be under-delivering. Actually, as a health service, I think we've been pretty good at trying to support staff to work at home where possible. But the very nature of our business does limit that to some extent.
I believe that our site is one of the ones leading that in terms of the number of staff that actually are working from home, because it is a challenging area. However, apologies, Aresh just showed me something and I haven't got my glasses, so I can't read it.
Sign of aging and a comorbidity in itself.
You can't see that through the radio. It's probably winding me up. But also, in terms of the process that was set up, and that's why I did take a little bit more time, is that we also assess the workplace at home and ensure that staff are safe working from home, and that we've got good governance over that as well. So I think it was worthwhile in that sense.
Yeah, it's interesting, isn't it? Because you're right about this issue of governance, because certainly the CCC have made some commentary around making sure that we don't lose track of what's happening in our organisation during this period of significant upheaval. Valerie, I've got a couple of other questions if I could ask you. The first one is around volunteers and when they'll be returning, and I know there's been some communication internally regarding that. Any reflections on volunteers?
Yes, I'm quite connected with the system at the moment in terms of the workforce planning group. So I did pose that question. At this stage, there's no intention for our volunteers to be coming back. What they're going to look at is the visitors' restrictions policy in the first instance, and then, of course, just gauge, given our news today, what the restrictions look like across the state and where we stand. But we're just conscious that with our volunteer group, quite a large percentage would be in the high-risk group. Many aren't. We do have quite a large percentage of volunteers that are young as well, which is really great to see. But we need to ensure that their safety is considered. So there's no intention to come back just as yet.
Can I just want to, thanks very much around that. I just want to just do a tiny bit of celebration and thank a member of the community health team who's communicated saying that they'd like to suggest actually many staff experience compassion, satisfaction, and that's where they choose to be. So that's fantastic to see, fantastic to see, and thank you for doing some positive reflection. That's really good. And I've not mentioned the person's name on this occasion, but next time I think when we see names, I'll presume that their anonymity is not being sought. And I think the second question that's come through is around the use of mobile phones around the wards with the COVID app. And I'm just going to start by saying at present there are probably two big messages we want to go across. We absolutely want the COVID app to be downloaded, and we are hugely supportive of that. The second is we are asking for it to be downloaded on all work phones. But for some areas in our organisation, having a work phone that's a mobile phone, has been reported back as interfering with equipment. So for the moment, we are suggesting that your people's personal mobile phones are a tool in order to help support the fight against COVID in the community, and that there are other mechanisms in terms of tracking and managing contacts within the organisation which are pretty robust. So for the moment, I'm going to suggest that people keep adhere to the current rules and regulations around personal mobile use at work, but absolutely download it. It's fantastic. I saw that, Beck, you presented a text raising concern about our current activity levels and what that means about the hospital's income. So there's no doubt that our activity levels at present are significantly lower than they have been. I hope I'm not being presumptuous in revealing that we have done some forward planning regarding how what the end of year position is going to be. So the finance team have done some projections around activity. So I think because we have had a year which was so busy earlier on, we are still predicting that our activity will be over that has been purchased, and as a consequence, we are hoping that our revenue won't be affected. I will, I think, give the message that I've always given out, that our staff are our most valuable resource, and we have not talked about staff numbers in the setting of revenue at all. But I do think people are finding it very challenging coming to a work environment where activity is significantly lower. I would encourage two things. I think the first is to use that time to upskill, train, and dare I say it, do mandatory training. And I think the second is this is likely to be a very, very long road. And even though it seems, I think, an inappropriate use of leave to take leave at a time when we've got social distancing, I would again encourage people to take a break from work. It is stressful, and time out, I think, is a positive thing to do, even if we can't travel internationally or even inter or intra-state. I have another question. Yes, of course. So I've been asked about developing a roadmap to returning to normal services, and highlighting that there's recognition that it's a very complex situation. I think we absolutely have to have a roadmap in terms of the way we move forward. What normal or business as usual is going to be in the future, I think none of us can predict. There are definitely some things that have been a really positive change to the way in we work and way in some of our patients experience and can utilize our services that we wouldn't want to lose. And I think we also have to recognize that we've lost one or two elements which patients really valued. So they're absolutely, I think, CAHS and CAMHS have some unique their own unique challenges, just as much as PCH has. And as I mentioned earlier, we are going to be developing a roadmap, and that would, I hope, be highly respectful of the unique place CAMHS and CAHS have in delivering and supporting the children of Western Australia. So yes, absolutely roadmap, and of course the specialist and subject matter experts will be at the heart of doing that planning. And sorry, we're just going through texts. And okay.
No, that's okay. Good, Aresh. Valerie, some very good stuff there with regard to the wellbeing and so forth. That's the same sort of thing for communities outside CAHS and so forth. It's about the wellbeing of the staff, wellbeing of everybody, and once again the communication. It's a big part, two-way communication, communicating up and communicating down. It's definitely big part of organisations and successful organisations. So you've got some very good skills there, some very good skills. So I think Western Australia and certainly CAHS is very lucky to have you over here. So.
Thank you. And just what I missed is in terms of wellbeing, I will be issuing a wellbeing newsletter, which I hope will go out soon. I'm looking at this week or maybe next week. But that will come out regularly and will be aimed, as you've mentioned, to help with that communication. But I'm conscious that's only one way of doing it. And in terms of feedback through COVID, when I spoke to staff about wellbeing and a level of anxiety or the feeling of fear at that time, a lot of it had to do with communication. They wanted to feel informed of changes and how that would impact on them. Now, that's not an easy thing to do,
no, exactly.
As you've mentioned. So we will keep looking at that and attempting to shape our communication in different ways to reach different audiences and different individuals in the way that they feel communication is best for them.
That's great. Aresh?
So, Valerie, thank you. Chris, thanks. I know you'll be listening. I just wonder whether I could answer the last question, which isn't about what our favourite music is, or actually CAHS related. But it's what's your favourite biscuit, Valerie? So I know mine are chocolate hobnobs. So I just wonder whether you have a favourite biscuit.
I don't, because I love biscuits in general, except a Tim. You can't go buy a Tim Tam
and not eat it.
And but you have to have a coffee, and you've got to dip it.
Oh, beautiful! Wonderful.
Thank you.
So, thanks very much, Valerie, for giving up time. So we will be sending this out as a podcast to all staff later today, along with some show notes. Radio CAHS will be broadcasting every fortnight on Fridays, but there is some learning for us to do, and I wondered whether you could be gracious and feedback to us on emails, cars.coms@health.wa.gov.au. I know we'll have got some things very wrong, so knowing how we can make it better and share information that you really want will be fabulous. It's not possible to do this kind of thing without the help of many, and I just want to give a special thank you to people who got the very first Radio CAHS show off the ground. So Chris Tansel and Chris Kirkwood, who in telehealth, who worked incredibly hard to help us, the CAHS ICT team, Melissa Spartadors, John Morricombe, and of course it would be remiss of me not to mention DJ Tony from Radio Lollipop, and let me also just celebrate Radio Lollipop, who have really put in a huge amount of effort behind the scenes to make this a reality and allow us to have another form in which we can communicate together. So can I thank you for listening and ask you all to stay safe. Thank you very much and have a lovely weekend, a special Mother's Day weekend.